Hello, and thank you for joining this OncLive TV peer exchange regarding updates on the treatment of advanced liver cancer. The disease burden of hepatocellular carcinoma continues to increase, and only because of its aggressive nature, but also because the incidence of cirrhosis is rising. Despite our best efforts to treat HCC, there is a high rate of recurrence. In this OncLive TV peer exchange, we'll take an in-depth look at how to optimally manage patients with the multidisciplinary approach we currently have available. In addition, we'll look at which emerging approaches appear most promising. My name is Ghassan Abou-Alfa, and I'm an associate professor for the gastrointestinal oncology service at Memorial Sloan Kettering Cancer Center here in New York. Also participating in this expert discussion is Dr. Richard Finn, an associate professor of medicine for the Division of Hematology Oncology, Geffen School of Medicine at UCLA Medical Center. Dr. Riccardo Lencioni, a professor of clinical radiology at the University of Miami Miller School of Medicine, and director of interventional oncology research at Sylvester Comprehensive Cancer Center. And Dr. Amit Singal, associate professor and medical director of the liver tumor program at UT Southwestern Medical Center. Thank you for joining us. Let's begin. We'll start by discussing the multidisciplinary care when treating liver cancer. And I'll start by maybe asking all of you, what is the importance of multidisciplinary care in the HCC population? Richard, thoughts?
Unlike most malignancies we treat in medical oncology, liver cancer is almost always occurring in the context of underlying liver disease. Unlike colon cancer, breast cancer, where often these are in healthy people. So therefore, it's going to take this multidisciplinary team to optimally manage patients. And that will often include a cancer specialist, like a medical oncologist, a hepatologist, as well as the fact that operating on a sick liver takes expertise. So usually a hepatobiliary surgeon and probably a transplant surgeon, and then importantly, interventional radiology, given the importance of that approach.
Great. Amit, interestingly enough, we probably, Richard and I, will get calls from medical oncologists and they are presenting a case, and presumably the same thing might occur in a setting of a multidisciplinary team discussion. Why hepatologists should be there?
Well, as Richard was saying, I think the key thing is that HCC occurs in the setting of cirrhosis. So over 90% of HCC in the United States occurs in the setting of cirrhosis. And as Richard was saying, I think that oncologists haven't had the history of dealing with cirrhosis that a hepatologist have. And we haven't had the history of dealing with cancer like an oncologist has. And so I think that it really involves crosstalk between the two. And so we know that the degree of liver dysfunction strongly plays not only in terms of prognosis, but also treatment selection. So, for let's say for surgical resection, you need to have a compensated liver with no portal hypertension. And then liver transplantation, often the liver's on the other side where you have significant hepatic dysfunction. And so I think that while you're not only in the beginning when you're making the initial treatment decision, but also longitudinally as you're following patients through care, you need to continue to monitor the liver function. And that's where I think a hepatologist can really add a lot to the care of these patients.
Absolutely. And as we just heard, pretty much to reconfirm, liver cancer or HCC is two diseases in one, the cancer itself and the more likely than not associated cirrhosis. And as such, understanding what could be the potential benefits of therapy or management for the patient would require those kind of like two aspects of the disease addressed. With this said, Riccardo, where do you think an interventional radiologist will get their referrals from? Is it like where patients will be identified by a specialist in a DMT, in a management team, or is it a multidisciplinary team, or is it some kind of referral from a surgeon? How does this work for you?
Well, most of our patients are referred by the multidisciplinary tumor board specialists. So patients are brought, I would say, by anyone who is sitting at the tumor board. Hepatologists typically follow patients with cirrhosis, so often they have patients with small tumors detected during surveillance. Oncologists bring cases who are typically more advanced. Surgeons can discuss the opportunity of resection or transplantation versus interventional therapy. So it's a mix of different referrals, and we try to figure out on each individual basis, what can be crafted for that particular patient.
That's beautifully said. If anything, the data has shown, and this comes actually from UT Southwestern, that it appears to be that patients who are seen by multidisciplines, by different disciplines, will fare better. So it's not really a wishful thinking only, but really the input of the different disciplines will be quite critical. Most importantly, if anything, on behalf of all of my colleagues, I would urge any specialty you're in, please attend your multidisciplinary team meetings, because this is where really you can contribute to what we call the gray zones between the different types of therapy that might offer and that we're going to discuss in a minute.